Welcome back to Neurology 101 on the ProPA podcast. I'm Dr. G, and today we're launching our mini-series on central nervous system infections, starting with the most urgent and high stakes, acute bacterial meningitis. From classic board questions to real-world emergencies, this is the one you can't afford to miss. Let's dive in. Even with modern treatment, acute bacterial meningitis still carries a mortality rate of up to 25% in adults. Classic signs like nuchal rigidity and photophobia may be absent in the elderly or immunocompromised. One pearl: if the CSF glucose is less than 40% of the serum glucose, think bacterial. All right, let's dive into the kinderpatho. What is acute bacterial meningitis? Well, it's a life-threatening infection of the meninges, the protective membrane surrounding the brain and the spinal cord. Bacteria trigger an inflammatory cascade, leading to cerebral edema, increased intracranial pressure, and, if untreated, death or neurologic disability. The most common pathogens vary by age group, but in adults, think Streptococcus pneumoniae, Neisseria meningitidis, and also Listeria in older adults immunocompromised and pregnant. In neonates, think Group B strep, E. coli, or Listeria. Now let's look at the clinical presentation. Well, the classic triad is fever, nuchal rigidity, and altered mental status, although these are not always all present. Additional findings include photophobia, headache, seizures, vomiting, and a petechial or purpuric rash, especially in meningococcal cases. The special signs to look for are also Brudzinski sign, which is when neck flexion causes hip and knee flexion to happen, and Koenig sign, which is pain with passive extension of the knee. So how do we diagnose acute bacterial meningitis? Well, we are going to do step 1 first. Check for contraindications to an LP. This means getting a CT of the head first to make sure that there are no signs of increased intracranial pressure, like focal deficits, seizure, altered mental status, or papilledema. Step 2, we're going to get that lumbar puncture. We're going to measure the opening pressure. We might see that it's elevated. We're also going to get those CSF findings of low glucose, high protein, and neutrophilic pleocytosis. We also want to make sure to draw blood cultures ×2 before we initiate antibiotics. So, how do we treat acute bacterial meningitis? Well, we want to start empiric antibiotics ASAP. We don't necessarily need to wait for the lumbar puncture, but we should try to get those blood cultures before. Adults less than 50, we want to use ceftriaxone and vancomycin. Adults greater than 50 or immunocompromised, we want to add in that ampicillin for Listeria. We can also consider giving dexamethasone before or with the first antibiotic dose, especially in pneumococcal meningitis. Timing matters. Each hour of delay worsens the outcome. Now let's look at the book med versus the street med. So book med is going to give us that classic triad plus the CSF findings, and we're going to use empiric coverage. Street med, it's 3 a.m., we got a college student who comes in confused, febrile, stiff-necked, and you get blood cultures, a CT, then an LP, but you already gave ceftriaxone, vanc, and dexamethasone in the trauma bay, and that's how you save a life. All right, some quick clinical pearls. Always start antibiotics even if we have to do it before the LP, especially if delayed. Ideally, we would get the LP and the blood cultures before starting antibiotics or simultaneously. But if we have to or have any delay at all, we should initiate those antibiotics. Don't miss Listeria coverage in the elderly, the neonates, pregnant, or immunocompromised patients. Close contacts of meningococcal cases need rifampin prophylaxis. Classic CSF profile is going to show low glucose, high protein, and increased PMNs. We also want to check the vaccine status. Many cases are vaccine preventable, like Hib, pneumococcal, and meningococcal meningitis. All right, now it's time for some practice questions. Number 1, a 25-year-old presents with fever, headache, photophobia and nuchal rigidity. LP reveals low glucose, elevated protein, and 800 neutrophils. What's the most likely diagnosis? Is it A, viral meningitis, B, tuberculosis meningitis, C, bacterial meningitis, or D, subarachnoid hemorrhage? I'll give you a few seconds. If you answered C, you are correct. This is definitely bacterial meningitis. We have that neutrophilic predominance, low glucose, high protein, and this is going to be classic. Question 2. What is the appropriate empiric therapy for a 70-year-old patient with suspected bacterial meningitis? Is it A, ceftriaxone plus vancomycin? Is it B, ampicillin plus cefepime? C, acyclovir plus dexamethasone? Or D, ceftriaxone plus vancomycin plus ampicillin? I'll give you a few seconds. If you said D, your answer is correct. Remember, we want to add on that ampicillin for Listeria coverage in the elderly and immunocompromised patients. All right, so some final thoughts. Acute bacterial meningitis is a true emergency. We need to diagnose it quickly and treat faster. Knowing who's at risk, what bugs to cover, and when to act could save your patient from permanent damage or worse. Next up in our CNS infections mini-series, we have brain abscesses, a localized infection with a very different presentation and workup. Did this episode help you? Share it with your study group, and don't forget to review your empiric coverage by age group. And as always, this is the Pro PA Podcast, where future pros in medicine are made. Until the next episode.